So, hello and welcome, and it's a great pleasure to once again be here, albeit virtually, at the Limits meeting in Brazil. My name is Perry Elliot. I'm a professor of cardiovascular medicine at University College in London and a consultant cardiologist at St Bartholomew's Hospital. And today I'm going to talk to you about some of the major developments in the diagnosis and management of cardiac amyloidosis. These are my disclosures. So cardiac amyloidosis refers to the deposition of this characteristic amorphous protein within the heart, shown in the top left-hand panel with this pale pink substance between the cardiomyocytes. And in the bottom left-hand panel, you see exactly the same section, this time under polarized light, demonstrating so-called apple green birefringence, one of the characteristics of amyloid fibrils. Amyloid may occur as a result of misfolded proteins of many different kinds, and I've listed some of them on this slide. But in cardiac amyloidosis, over 90 to 95% of cases are caused by the deposition of one of two types of protein. The first is immunoglobulin light chains produced as a result of a plasma cell dyscrasia. And the second is the deposition of transthyretin, or what we used to call prealbumin, a transport protein secreted by the liver. And of these, it's the second which is by far the most common. In the case of TTR amyloidosis, the disease pathology is thought to arise as a result of dissociation of the native protein. TTR is a tetramer, and it's thought to be dissociation of this tetramer into its component monomers or other fragments, which is the first key step in the formation of TTR amyloidosis. TTR amyloidosis itself occurs in two main forms. There is a familial form caused by mutations in the TTR gene. And this can manifest with multi-system manifestations involving the central nervous system, the peripheral nerves, the kidney, the gut, and the heart. The clinical picture, however, does seem to be, at least in part, related to the underlying mutation. Some mutations, for example, the V30MET, which is endemic in Portugal, for example, seems to be largely a familial early-onset polyneuropathy. Conversely, there are other mutations, such as the T60A, which seems to result in largely a cardiac phenotype. Probably the commonest genetic mutation to cause amyloidosis is the V122I. And this occurs in maybe 3 to 4% of individuals of Black African descent. And whilst not every carrier of mutations in that gene develops amyloidosis, it is very clearly significantly overrepresented in heart failure populations. To the cardiologist, amyloidosis may present in the familial form, and in this instance, the age of presentation can be quite variable, but nevertheless, there is still a male predominance, and patients may have other neurological manifestations, such as dysautonomia, as well as ocular manifestations and peripheral neuropathy. Much more commonly, we see what we used to call the senile form, or what we now term wild-type TTR amyloidosis, which is largely a disease of individuals over the age of 60, again with a significant male predominance, and this is largely cardiac except for presentation with carpal tunnel syndrome and less commonly biceps tendon rupture. In textbook descriptions of amyloidosis, the low voltage ECG is said to be characteristic, and you may certainly see this in some patients, along with conduction disease, atrial fibrillation, and a pseudo-infarct pattern. But I think it's important to realise that the low voltage pattern is a relatively late finding in amyloidosis, and the presence of a normal voltage or indeed even left ventricular hypertrophy is entirely consistent with the diagnosis. Here you see slides showing the pathology within the myocardium, and you see here characteristically concentric thickening of the left ventricle, thickening of the free wall of the right ventricle, and infiltration of the interatrial septum, bottom left, and the mitral valve, bottom right. And we see these the equivalent of this pathological abnormality on echocardiography, again with concentric hypertrophy, often with biatrial enlargement, small pericardial effusion. You may also see a restrictive filling pattern, but this is present usually in only about 20 to 30% of patients. Here you see some examples again. On the left, concentric hypertrophy, and on the right, this characteristic thickening of all segments of the left ventricle with atrial enlargement. Note here that the ejection fraction is often within the normal range because of preservation of radial function. But regional deformation is often very abnormal with a marked reduction in long axis function. And as you can see on this slide on a longitudinal strain map, this characteristic apical sparing pattern. Now, amyloidosis, I think, has come to the fore recently for three main reasons. And the first of these is improved diagnostics. I think that one of the most important advances that has increased the frequency of diagnosis is cardiac MRI. Here you see again that the same as we've just seen on the echo, so concentric left ventricular hypertrophy, some thickening of the right ventricle, marked reduction in long axis function, and biatrial enlargement. But the really almost pathognomonic feature you see on MRI is this dramatic expansion of the extracellular space, often with, on late gadolinium contrast imaging, this diffuse pattern or subendocardial pattern. This is highly characteristic for amyloidosis in the right context, but it does not distinguish between the two main amyloid types. This test, on the other hand, is extremely useful for the non-invasive diagnosis of TTR amyloidosis. This is bone scintigraphy. And for reasons that are still poorly understood, bone tracers, such as DPD or other pyrophosphate tracers, seem to have great avidity for amyloid fibrils where the source protein is TTR. And here you see on the right-hand panel, C and D, examples of a patient with avid uptake on a bone scan. And this, as I say, is a very sensitive and specific marker for TTR amyloidosis, to the point where biopsy is no longer necessary to confirm a tissue diagnosis. And indeed, this is now incorporated in diagnostic algorithms such that if you have echo or MRI features consistent with amyloidosis, one should then perform a DPD scan and also look for evidence for a plasma cell dyscrasia in blood and urine. If the DPD is positive with no evidence for dyscrasia, then you effectively have a diagnosis of TTR amyloidosis. If there is evidence for dyscrasia, then irrespective of the DPD scan, a biopsy may still be necessary. New tracers that are now being evaluated are PET tracers based on thioflavin T, which is an amyloid-avid dye. These seem to bind directly to the amyloid fibrils and seem to provide a very sensitive marker of early disease, quantitation of the amyloid load, and recently some suggestion that we can perhaps distinguish between AL and TTR according to the kinetics of the tracer. The second major driver for change is this new epidemiology as a result of the application of these new tests. And you see this dramatically in the frequency of diagnosis of TTR amyloidosis at the National Amyloid Centre in London, with this dramatic increase in the number of patients with wild-type TTR, almost certainly reflecting the greater use of MRI and latterly bone scintigraphy. And when you apply this to maybe more common cardiac populations, for example, as in this case, heart failure with preserved ejection fraction, here you see a prevalence of up to 13%, 13% of patients with a clinical diagnosis of HFpEF with evidence for TTR amyloidosis. If you look at patients undergoing TAVI for aortic stenosis, up to 16%. If you look at patients having surgical aortic valve replacement, maybe 6%. So clearly, there is a large body of undiagnosed amyloid. The third and perhaps most important driver for change is the fact that amyloidosis is now potentially a treatable disease. I'm not going to talk about light chain amyloidosis, but other than to say that if treated early enough with appropriate chemotherapeutic agents, one can put patients into remission and significantly improve their likelihood of survival. And this is why, if you have patients with suspected amyloidosis, you should very early on exclude AL, because the difference of 6 months can make all the difference between surviving and dying from the disease. For TTR amyloidosis, there are a number of approaches that are now being evaluated, all of which are targeting the production of TTR in the liver, or in stabilizing the TTR tetramer, or potentially removing fibrils from the heart. So far, only one of these has been subjected to a randomized clinical controlled trial in patients with cardiac amyloidosis. And this is a drug called tafamidis, which is a TTR stabilizer. And as you can see in this randomized trial of patients with TTR amyloidosis, both hereditary and non-hereditary forms, there was a 30% reduction in absolute mortality and stabilization of disease with a dramatic reduction in the decline in symptoms, quality of life, and 6-minute walk test. Other approaches now being explored target TTR gene transcription using RNA technologies such as antisense oligonucleotides, and these have been shown to be effective in patients with polyneuropathy and are now being evaluated in patients with TTR cardiomyopathy. And most recently, we have gene editing, what was until very recently sort of more science fiction than science fact. But here you see in this recent paper published in the New England Journal, using gene editing by introducing the Cas9 complex with a targeted RNA sequence which specifically binds to the TTR gene and introduces a break in the DNA, therefore rendering the gene inactive. You can see that in these 6 patients, there was a dramatic reduction in the production of TTR. So if this could potentially represent a cure. So I think that the take-home message about cardiac amyloidosis is that it is far more frequent than we previously suspected. The diagnosis can usually be made non-invasively using a combination of MRI, bone scintigraphy, and the exclusion of AL amyloidosis. And most importantly, that AL amyloidosis is now potentially a treatable disease. And I leave you with this slide from 1964, where Aurelia Pomerantz said, even then, that this was an underdiagnosed disease by clinicians and pathologists. I think with the technology we now have available, this should no longer be the case. Thank you very much for your attention.